My name's Sanjeev Agarwal. I'm the President and Chief Operating Officer of LeanTaaS. My goal over the next 45 minutes or so is to give you a high-level overview of what's happening in AI, where we've come from, where we are, and where we're going. If your newsfeed is anything like mine, not a day goes by without so many exciting developments. 3 months ago, it was ChatGPT. Now it's images, it's video, and the inordinate ability for AI to start mimicking what human beings can do. Some of it is real, some of it is frankly hype. So how do we tell the wheat from the chaff? And that's my job over the next 45 minutes to demystify for you. So here's a quick outline of what we're going to do. We're going to talk about the power of AI ML, specifically applied to hospital operations. Then we'll talk about some use cases where high ROI can be achieved and what the state of the art is. We'll spend a little bit of time on what we call the magic equation, because AI in itself cannot deliver results. It takes a lot of change management. It takes a lot of embedding AI into workflow to make magic happen. And then finally, I am really excited. I am thrilled to launch what we call IQ Autopilot. IQ Autopilot is our foray into generative AI, the next step in the evolution of AI. This is the first of its kind in its industry, and we'll talk through what that means for you. So let's get started. Before we launch into specific use cases, maybe we should spend a few minutes talking about how we at LeanTaaS even define what AI is. And the best way to do that is to illustrate that through a few examples we all have experienced either recently or at least at some point in our lives. So let's start with some really easy ones. I don't know anybody who has not used a navigation system or a service like Uber or Lyft. And the reason this is so remarkable that services like navigation systems and Uber and Lyft work is that every time I call one of these services, I have an Uber or a Lyft show up in 5, 7, 10, sometimes 2 minutes. Doesn't it amaze you? How did Uber or Lyft know that I was going to be calling? I'm one of 350 million Americans. On any given day, at any time, I could wake up, pull out my mobile phone and say, I want a car service. Or if I land at an airport and I want to navigate to my hotel, and I ask Google Maps or Waze how long it's going to take to get from point A to point B, more often than not, it gets it almost precisely down to the minute. Monday at 3 o'clock is very different from Friday at 2 p.m., and the results are accurate whether it's Monday or Friday. That's magical. How did they know who was going to be on the road, how fast they'd be driving, what the traffic conditions would be like, and yet they get it right? Let's think about walking into a UPS store. There are 40,000 zip codes in this country. You or I could walk into any one of these UPS stores on any given day, tell them I want to ship a package, a book, a tie, a watch. And they'll accept it, and they'll ship it for me. And I can ask for it to be shipped overnight delivery. I can ask for it to be shipped 2-day or a week long. They'll price it and they'll deliver against what I wanted. Imagine if the UPS front desk person told me, come back in 24 days. And I say this because that's the average amount of time it takes to get a primary care appointment in this country. Think about the fact that when I go and book an airline ticket, again, 5,000 airports in this country. If I go to delta.com and I book a ticket, Delta had no idea I was going to show up on a Friday at 3:01 and book a ticket. And yet, I have never encountered a situation where any of the websites, whether it's Kayak or Google Flights, doesn't allow me to book a ticket from any point to any other point in this country. How do they match a highly uncertain supply and a highly uncertain demand? And of course, now we're living in the world where machines are starting to understand context and generate content for us. Even a year or two ago, if you were using Gmail, it would start generating the next few words for you as you were typing your response out. Now, of course, we could type in to ChatGPT that I want War and Peace set in 2023, and it'll probably give you a decent response. What's common about all of these examples and the way we define AI is for machines to be able to learn from historical patterns of behavior and predict the future in a way that's useful. All of these industries and businesses have essentially taken historical data, broken it down into small bite-sized chunks, and delivered value by being able to predict what's coming. So the way we define AI is to know precisely what's coming in order to be able to take the right action. And if you look at the examples of all of these companies I talked about, whether it's Google, whether it's UPS, whether it's Delta, whether it's Uber, what's common about them is they have created ubiquitous access to their services, pleased customers to the extent that their businesses have grown a lot, happy users, profitable companies, huge access. Now let's contrast that with the patient experience in our hospitals. If you think about going to any ED in this country, or if you've ever been to an OR in this country, you can be waiting for hours to be boarded even after you've been seen by the doctor or been operated on. Don't you wonder? If I have elective surgery, the hospital knew I was coming. They told me what time my surgery was scheduled for. And yet, why do I have to wait 3 hours in the PACU? Why wasn't a bed available for me when I needed it? If you think about just how long it might take to even get a primary care appointment, it takes 24 days on average to get a primary care appointment. Imagine if I needed to see a specialist. That could take months. By the time I actually go to my appointment, I probably don't even need it in many cases. If you think about how long it takes to schedule surgeries, for example, my surgeon, the one that I like, might be fully booked out because their block time is fully spoken for the next 3 to 6 months. If I need to get surgery done on my knee and I need to get it done very, very soon, I may not have a great option if I want to stick to that one surgeon that I like. And there are many examples like this. You know, if you think about infusion centers and how long it takes to get appointments there, and when you show up, you have to wait a long time. People with their colonoscopies, people for their MRIs, have all these ambulatory appointments which might take forever to schedule, and even after you schedule them, you're waiting. And if you think about all the other examples I gave you, for example, if you ordered an Uber and even had to wait 20 minutes to get a response, you'd probably just give up on it and call for a Lyft or a taxi. So our expectation of services that we take advantage of in our daily lives is so much higher than the experience we're able to provide to our patients. Why is that? The reason that's the case is that the methods we use to manage capacity relative to the methods these other asset-intensive industries, the UPSs, the airlines, the Deltas use, is very different. In health systems, the way we manage capacity is often through rules of thumb. Let me give you a few examples. If you're creating an ambulatory schedule for a clinic appointment or for an infusion appointment, oftentimes that involves heuristics like long appointments in the morning, short ones in the afternoon. Meanwhile, if you think about 70 patients walking into an infusion center or 70 patients walking into a clinic, and they're all unique patients, you might remember from high school math that the theoretical way in which you could arrange these patients is 70 times 69 times 68, 70 factorial. That number is greater than 10 to the 100. Now, if I impose on that constraints like how many nurses I have, how many MAs I have, or how many infusion chairs I have, what my operating hours are, when my lab is open, when pharmacy is open, when the oncologist can see me, you've just added a whole bunch of constraints that need to be taken into account to come up with the precise pattern that will actually lead to a level loaded day, where we can maximize access and patients don't have to wait for a long time. So if you really need to take that solution space of 10 to the 100 and get it down to a template that actually works, and what you're actually doing is these rules of thumb, no matter what you do, Einstein couldn't do it by simple heuristics like that. You need a big server in the sky doing these optimizations. No wonder every infusion center you walk into, between 7 and 10, it's a fairly lightly trafficked center, not many patients. Between 10 and 2, it's a zoo. And between 2 and 5, again, we've got the other shoulder where traffic drops off. And that has huge problems in terms of staffing and the patient experience. Think about how we allocate block. OR committees gather and they use metrics like block utilization to right-size block. Lots of problems with block utilization. If you take a day where a surgeon starts 10 minutes late, which might not have been their fault, Maybe they have a 15-minute turnover instead of a 10-minute turnover. And maybe they're efficient and they end 15 minutes early. We penalize this surgeon for the 10 minutes, the 5 minutes, and the 15 minutes, which, if you add them up, gives you 30 minutes. In most cases, unless it's an eye surgery, cannot be done in 30 minutes. So what is the point of holding our block owners accountable for a metric that actually makes no mathematical sense? Meanwhile, there are large contiguous portions of time being left that are being treated the same way as these small grains of sand. There are far better ways and mathematically optimized ways of looking at how much time can be taken away and right-sized to be given to the right surgeon. If you look at how we manage inpatient huddles and how every morning in every hospital in this country, we get together in these huddles and we talk to each other and we say things like, John, in the orthopedic unit, how many patients do you expect to be discharged? How many patients do you expect to come in? By the time the huddle is over and we gather everybody's input and we create the scratch pad of paper, reality is different from what it was when the huddle started. The ED no longer looks like what it looked like at 7 a.m. The OR might be running late. Maybe a couple of cases got canceled. So our source of truth, this piece of paper that's set together at 7:30, created with what I call abacus level math, is just wrong. And we run our operations for the next 3 or 4 hours based on this kind of thinking. Meanwhile, Google is able to look at data of historical traffic and predict all those traffic patterns to tell you exactly how long it's going to take to get from point A to point B. That data, the equivalent data, exists in the timestamps in your EHR, unit by unit, day by day, much like mobile phones have moved across different latitudes and longitudes. Patients have moved unit by unit, and we have that data that could be used to make very similar predictions. When we think about staffing, we have these monolithic 6-week schedules based on average demand, as opposed to a very precise prediction of demand. If we could tell you, or you could use your own data to tell yourself what the likely projection, the likely volume of cases will be done in the future by type of case, inpatient, outpatient, by surgery, service line, you'd have a huge leg up in terms of accurate staffing that's based on demand as opposed to averages and guesses. Now, the reason this is becoming really critical right now is we cannot afford to not, as a country, squeeze the most juice from the assets we have. So if you think about hospital economics, we're all very well aware of the situation that there is a huge increase in demand for care. We're all living longer, the population's growing, and the two parts of the curve where people need more healthcare are kids below the age of 10 and folks above the age of 65. Both those segments are rising in volume. At the same time, staffing is shrinking. There are more doctors and nurses leaving the workforce than entering it. Most of our supply is constrained because there isn't free capital to build more ORs anymore, or put more inpatient units anymore, or build more chemotherapy centers. And if you do, they're very, very expensive. On the revenue side, it's not as if reimbursements are increasing. We're already 19% of GDP as a set of health systems. But the bizarre part of this is that if we measure asset utilization of assets we have already invested in the ground, they're very poor. The average OR utilization in this country is 55%. So how can it be the case that it's so hard to get time in the OR that I have to wait weeks and months to get my surgery done, but then when I go and measure the utilization of the asset, it's less than 60%? That's a conundrum we have to solve, especially because the patient experience has never been as bad as it is now. And I just read a stat the other day that the average net margins of a hospital in this country are actually zero. We aren't making any money, and the situation is getting worse. So if we're able to actually squeeze these assets, get more surgical cases done with the same number of rooms and the same number of staff, if we're able to increase our bed turns using the same type of matching of supply and demand through much more fine-grained mathematics than we currently do, that can make a 2 to 3 percentage point difference in EBITDA. And we'll talk about that as we go through these examples. So what is it that's required? When we think about analytics in a healthcare system or in any system, you might argue we have analytics. We have the EHR, we have Tableau, we have a lot of reporting. Why is it that we're not able to get to the level of sophistication of a Delta or a UPS or an Uber? Here's why. If you think about what analytics is not one monolithic thing. Analytics is actually a spectrum of capabilities, starting with the most rudimentary. The lowest level of maturity is what we call descriptive and diagnostic analytics. Descriptive analytics is really talking about what happened. It's sort of like yesterday's newspaper. If I gave you yesterday's newspaper and told you it rained between 11 and 1 p.m. yesterday, that might be interesting to you, but what do you do with it? It's describing, or what I call admiring, a problem. After that, maybe we can diagnose why that happened. There was a high-pressure system that built over the bay, and then it rained. Okay, that's interesting perhaps for some reason, for some people, but that doesn't tell me what to do tomorrow. Magic happens when you actually are able to take these historical patterns and you're able to actually predict what's going to happen. When you understand weather systems well enough, which we now do, that the weather report for tomorrow starts to get more and more precise. Because then if I tell you it's going to rain tomorrow between 11 and 1, you can prescribe yourself an action. You can say, I'm going to stay home, I'm going to get wet, or I'll take an umbrella. That's up to you. But it's not until you use these historical patterns to predict what's going to happen that any of these analytics actually become useful for you. Scoreboards don't drive action. And my favorite example is, imagine the LA Rams going back after the Super Bowl this year and saying, you know what? We're going to get really good scoreboards in our stadium. I doubt they'd win the Super Bowl because they kept changing scoreboards. And that's the problem with a lot of static dashboards that admire the problem. Now, until 6 months ago, this is where this picture would have stopped. Now, the most interesting, the most explosive revolution in AI, as you know, is this thing called generative analytics. AI was supposed to be, as I described before, taking historical patterns of data and predicting the future. Now, not only can you predict the future, you can actually generate text, videos, images by giving human prompts that doesn't require you to be a coder. If you've used ChatGPT, or if you've used Bard, or if you've used any of these digital assistants out there. And we'll talk a little bit at the end about how our version of generative AI can really take away a lot of the mundane, repetitive activities, improve productivity, patient and staff satisfaction. So given this spectrum of potential of what AI does, let's first start with the middle section. What can predictive and prescriptive analytics do? Then we'll talk about generative analytics, or generative AI. So if you think about whether you call it machine learning or predictive analytics or predictive and prescriptive analytics, at the end of the day, what it is it's teaching a machine to behave in a way that a human might learn, look at historical patterns, predict the future, and help you take the right action. To make this real for you, let's go through a few use cases in 4 of the most common and big areas of ROI. Let's start with the operating room. The operating room is the economic backbone of a hospital. More than 60% of revenues, often 60% of profits and margin, come from the OR. The way we allocate capacity in block has many advantages, but it also has many disadvantages. Block becomes a rite of passage. People don't necessarily voluntarily give it up. We come up with rules like auto-release that aren't really based on much sophisticated mathematics or an understanding of booking patterns. So let me give you a few examples of what's possible today through the use of predictive analytics. Imagine being able to study booking patterns of surgeons to be able to know pretty much whether they're going to use block on a future day or not. To make this real for you, I've sat in OR committee meetings where people have made decisions like, we are going to set our EHR auto-release of block time at 2 weeks, or 2 days, or 1 day in some cases. Or we might get a little more fine-grained and say, by service line, we're going to make it different. Neurosurgery has a 2-day auto-release. OBGYN might have a 2-week auto-release. The problem with that is that neither of them are based on any real understanding of reality. All of this data exists. How long before day of surgery has every surgery been booked? Imagine studying those patterns, much like the navigation use case, and coming up with probabilistic measures that on any given day of the week tell you fairly precisely the likelihood of any block owner actually using their block in the future. And when the likelihood starts to go down, when you are 50, 60, 70% sure that they won't, because by now they should have had a case on the grid based on their historical usage, how about pinging their offices and saying, hey, I know Dr. Agarwal has time 4 weeks from now, based on his past booking patterns. By now he should have had a case on the grid. He doesn't. Would you please release that time? And if I don't, or my scheduler doesn't, imagine holding me accountable for that by having the data to prove that I ignore these release reminders and then I still don't use my block. A sister analogy to that is the ability to predict with high reliability how well a block is going to be used in the future. So even if I, as the surgeon or my office, doesn't release it, schedulers can actually overbook slightly with high confidence, much like airlines overbook. And they go to an extreme. Sometimes they book 150 passengers for 100 seats. I wouldn't recommend doing that. But if you knew with 99% probability that if you booked 1 or 2 extra cases in someone's block time, you would get away with it because you're pretty sure they're not going to use their block well, that's worth thinking about. Let's talk about case length prediction. Case lengths are very interesting. Einstein couldn't precisely predict how long a case is going to take, but he'd get a lot closer than global averaging. The problem with global averaging is the problem with all averages. If my head is in the freezer and my feet are in the oven, on average my body temperature is okay, even though I'm dead. So when you take CPT codes, or let's say 2-level spinal fusions versus 4-level, and you average them out, they're meaningless because they're completely different types of cases that obviously take very different amounts of time. So imagine using natural language processing, similar to what large language models use for ChatGPT and other applications, and being able to determine, is this a 2-level or is this a 4-level? And being able to cluster them, much like these recommendation systems cluster people with other people like them based on the characteristics of the individual, and only compare for a given surgeon and for a given type of case how long that case is going to take. Then whether you take the median or the 70th percentile or the 90th percentile depends on you, but you'll come far closer to estimating how long a case is going to take than what you might be doing today. Many, many other examples we can talk about in the OR, but that being the economic backbone, these sorts of tools can free up tremendous amounts of capacity. You'll see the results in a minute. Imagine being able to do anywhere between 5 and 20% more cases per OR per year. That's 30 to 50 extra cases per OR per year for most operating rooms that we know. Let's talk about inpatient flow. Think about the fact that instead of using our best guesses at morning huddles, we're able to use the data in the EHR or your bed tracking system to be able to predict precisely short and long-term census forecasts. By day of week, by hour of day, by unit, tell you the number of patients, the ingress and egress of patients for those units. How? The same way that navigation systems work. They look at historical patterns of the ingress and egress, the throughput, for every segment of road, by day of week, by time of day. It's exactly the same logic that can be applied to look at historical patterns to predict far more precisely than, frankly, any huddle that we've seen can do. If you can do that, imagine adjusting staffing based on that well into the future, because you can do these predictions for 24 hours, 48 hours, 72 hours, and even a week or two in advance. I touched on staffing earlier in both the OR and the inpatient contexts, but imagine being able to, for example, predict future OR volume. Delta Airlines every day has a pretty good idea of many days into the future what the likely number of passengers are going to be between any origin-destination pair points. They do that by mining historical data and predicting what's going to happen. That's how they price. Using very similar logic by looking at historical timestamps of surgical volume, you can predict how many cases of what type by service line, by day of week, by location will be done in your ORs. How many inpatient versus how many outpatient. Imagine being able to adjust staffing based on the precision of that data. Similarly, for inpatient units, we talked about this as well. The idea that if I could predict patient census hour by hour, location by location, day by day, unit by unit, my ability to adjust staffing instead of taking some sort of average coverage ratio goes up, and it's far more precise. Let's think about ambulatory environments, clinics, infusion centers. I gave you the example earlier of the 70 patients walking into a clinic or an infusion center and the fact that there are 10 to the 100 choices of the sequence in which these patients can come in. Now imagine creating an optimized template that takes those possibilities and constrains them with things like, how many nurses do I have? How many simultaneous starts can I possibly manage? What are my pharmacy hours? How staggered are my nursing shifts? When do people need to take breaks? So they have lunch breaks and breaks during the day. You impose those constraints on those 10 to the 100 possibilities, and out pops a template that actually meets all those rules. That's impossible to do by hand. You take those optimized templates, you lower the invariable peak that happens between 10 and 2. You're able to accommodate more patients, and all of them weight less. You'll hear about all of these examples, by the way, in real life from many of the presentations that are coming up over the course of today and tomorrow. And here's where I want to introduce this, what I call the magic equation. Oftentimes, we get so lost in the hype of AI, in the promise of these tools. We forget the fact that to get the benefit from these tools, A, they need to be accurate and precise and give us the right information. B, they need to naturally fit into our workflow. And C, our users need to be happy in using them. So when the navigation system first was launched in cars, the first set of users needed not just to be excited about it, but it needed to be easy for them to use when they sat in a car and they programmed it. The first set of navigation systems, if you remember, were very clunky, really hard to use with those buttons that you had to dial. I'm old enough to remember them, as opposed to now touching my screen and being able to speak to it and say, take me from point A to point B. They didn't become part of my daily existence until they became easy to use, part of my workflow, and they never got it wrong. So artificial intelligence has to be the starting point of your transformation to be able to squeeze the most from your assets, but that alone won't do. That artificial intelligence has to be on data that you can rely on. I'll give you an example. We work with 600 infusion centers in this country. And a lot of times when we get timestamps, those timestamps say that 5 patients checked out exactly at 5 p.m. It's no one's fault. The person who entered that information was busy taking care of patients, and so they decided at the end of the day that they would just check everybody out at 5 o'clock. But if you use that data to make your predictions on that template I was talking about, you'd get it all wrong. So unless you can clean that data up either through RTLS or some kind of tracking or rules of thumb and heuristics like checkout time was probably check-in time plus expected length of appointment plus maybe 10 or 15 minutes. Or if you had some other timestamp in the intermediate term, like last drug start, and then you added some time to it. So a lot of data hygiene is important to get this right. Secondly, in the scheduling workflow, this has actually got to fit with the way schedulers actually schedule. That's the part about data hygiene and workflow management. From a change management perspective, users have to be comfortable using these tools and actually enjoy them, the user interface, how they interact with those tools. It can't be 7 different ways of using the tool in ways that are clunky with 12 clicks. And that's, by the way, where generative AI can play a huge role. But just modern day software is so much better than tools designed decades ago. If you get these 3 stools of the equation right, the growth ROI and this ability to work like a system, which we call systemness, is huge. And again, you will see real-world case studies from several speakers after me when they show you how they've gotten these 3 elements right to achieve the kind of growth and ROI we're talking about. Let's go through the 3 areas I talked about and go maybe one level deeper into the types of KPIs you can expect were you to adopt these kinds of tools with the change management and the workflow. In the operating room, What we've seen across 90 health systems, roughly 5,000 ORs that we work with. After this, you'll hear from Brian Dawson at Common Spirit as an example, where he will talk about, and I'll give you the punchline, a 40 million annual contribution margin improvement from the use of these tools I was talking about. On average, we've seen a 6% improvement in case volume, a 7% improvement in staffed room utilization, which is this key metric of I'm already spending money and time staffing block time, and can I use it better? An increase in prime time utilization, which is fairly impressive. 4% is the median. It can be much higher. It could be as high as 10%, 15% in some cases. And then, of course, block utilization. Block is sacred, and if we can assign the right block to the right individual through this collectible time process, learn about the signals of their usage through how they're using time outside of block to allocate the right block to the right individual, you'll also find block utilization going up. Net, the time to value, how quickly you can get value from this, is in the order of weeks and months, not years. And the ROI that's delivered is 15 to 20 times the cost you might pay for tools like this. So that's on the operating room side. On the inpatient capacity side, very similar and very, very impressive metrics. Things like improvement in bed turns. If we can predict what the barriers to discharge for a patient likely to be discharged tomorrow or the day after are, and take care of them today so they aren't held up at discharge. If we can prioritize which patients should be discharged first because those beds will be needed sooner, we can empty beds faster, send the right patient home with what they need, and get the right patient in faster, which is how we can get bed turns up by almost 20%. If you think about how long it might take or how much we can reduce boarding time in the ED and the PACU, you can get 35 to 40% improvement in how long your patients are waiting. If you think about number of opportunity days, i.e. days that insurance is not going to reimburse you for, whether it's Medicare or any other insurance type, imagine reducing the number of opportunity days on average by 8%, where each opportunity day might be worth $1,000 for you. So for a 400-bed system, 400 times 365 times 8% times $1,000 is a lot of money. Think about reducing the cost of travelers and staff that you don't need. Why? Because you've been able to fine-tune your staffing based on predicted demand and census that is fairly accurate. If you do all of these things, your ROI is anywhere between 10 and 12x. And again, you'll see case studies very soon on the inpatient side as well. Very similar story on infusion chair utilization. If you use these optimized templates, if you're able to adjust your schedule, if you're able to manage you actively manage how your day looks using real-time tools, again, much like a GPS, you can see 15 to 20% more patients. And by the way, those 15 to 20% more patients will actually wait less during peak times. This is sort of like loading up an already busy highway with 15 to 20% more people, and all of them will go faster. That's the magic of the math. Think about staff being able to go home sooner because you have pre-engineered a way for them, for us to have the last patient out of a chair by 5 p.m. Think about the fact that identifying white spaces in these optimized templates so oncologists can send last-minute appointments, which always happen to your infusion center, and that patient doesn't have to wait a lot. That improves patient satisfaction and provider satisfaction. Here too, you'll make $4 or $5 for every dollar you spend. So all of these applications, and I'm just giving you a preview of some of the more expensive assets, but you could apply the same techniques to match demand and supply on any one of your expensive assets. In our minds, where this is going is what we call towards AI-enabled air traffic control for providers. If you think about what the experience of a passenger or a traveler, if you traveled, say, 25 years ago versus you traveling now, you may have noticed a lot of differences. I usually don't arrive at the airport more than an hour before my domestic flights. Why? Because I'm already checked in. I've already checked my bags in. All I need to do is hand them to someone to put on a conveyor belt to put them in the plane. The TSA line has been optimized based on an understanding of the amount of traffic that's likely to come by hour of day, by day of week, so they have the right number of lanes open. Yes, it might be long, but it doesn't take me more than 15 or 20 minutes, even on a bad day, in most airports. So I'm usually at my gate well on time before boarding. That wasn't the case 20 years ago. I had to stand in line. Someone would hand me a boarding pass. That might take 20 minutes. I had to check my bags. Someone else would physically do the work for me. The lines certainly weren't as optimized as they are today. So I'd arrive 2 hours early. What they've been able to do through this kind of automation for a passenger is the equivalent of air traffic control. Much more importantly, what they've been able to do for airplanes. Think about Atlanta Airport. Atlanta Airport is able to manage 10 times the number of traffic, 10 times the number of takeoffs and landings on any given day today than in 1985. They used to have 4 runways then, they have 5 runways now. Just a 25% increase in capacity and 1,000% increase in throughput. That's what healthcare needs. So if you think about a world where you have inpatient air traffic control and outpatient air traffic control, where the path of a patient can be managed as seamlessly as airlines have been able to manage traffic, that's what's going to get access up and costs down. Now, if you think about what the economic impact is for a 10 hospital system with, say, 300 beds, 12 ORs, and say roughly 10 chairs or 20 chairs, it's huge. If you add up the contribution margins that are delivered through squeezing these assets as well as we can, while increasing staff satisfaction, that's about a $100 million opportunity in contribution margin annually. And that's why you should care. And we know this because we work with over 600 hospitals across 49 states in this country. Almost every state has IQ presence. And we have been fortunate that we've had a ringside view to the transformation that these 180 or so health systems are going through by optimizing capacity utilization, optimizing patient flow through predictive and prescriptive analytics. Let's spend a few minutes on the future. I promised that I would talk about generative AI and where we're going. It is a very, very exciting new development in terms of the emergence of where natural language processing has gone. Many of you have probably used tools like ChatGPT and Bard. And in fact, they're so powerful that, as you know, ChatGPT is the fastest adopted consumer tool ever on the planet. Faster than Google, faster than Instagram, faster than any other tool that you or your kids might use. Over 1 billion users in less than 60 days. And that's happened because it has magically converted a complex web of information into a simple natural language interface where I can ask it a question, and most of the time, it gives me a reasonably accurate answer in a fair amount of detail if I ask it the right way. Now, when we think about projections that are being made by the gurus on how generative AI is going to apply to various industries, healthcare is at the top of the list. So this is a BCG report that talks about how fast they expect generative AI to grow. In healthcare, it's expected to grow 85% year over year for the next few years. A couple of reasons why. Healthcare data exists in digitized format, and we're able to use that. We're starting also from a fairly low base, and much more importantly, we're in one of those industries where we can leapfrog a lot of things that other industries have done. And so we should expect the adoption of these tools to be quite high. And so today I'm very, very proud and thrilled to launch the next generation of IQ tools. We're calling it IQ Autopilot, and you'll see in a second why. It's the first ever generative AI hospital operations solution ever. And I'm going to show you a video in a minute that talks about the types of use cases that we will address. So let me set up those examples for you and play the video to give you a sense of where we're going. Imagine all your mundane, repetitive analytics and tasks being able to be transformed by the use of tools like ChatGPT. And I give that as an example of one kind of generative AI. Let me give you 3 specific examples. Imagine my perioperative leadership wants to understand surgical volume and trends and reasons why it's trending the way it is. Or imagine that I'm trying to figure out which staff will be required in which units in my inpatient beds, and I'm planning for that. Or imagine that I have a block committee meeting coming up, and I need to decide who to take block from or who to give block to. Watch this 2-minute video. Let's watch it together to show what that future might look like. So here goes. So if that felt like magic, it's like Arthur C. Clarke said, that any great technology is indistinguishable from magic. And human beings and our creativity has led to us being able to even imagine a world where this exists. So how can you use IQ Autopilot? We're launching with the few use cases you saw, and we think there are 3 modes in which you can use IQ Autopilot. The one that we are all familiar with is what we call the lean forward mode. So we all lean forward to our computers, we type something into Google or into a web browser. Similarly, imagine typing into IQ Autopilot those questions you saw in the video and being able to get responses for them. An even more powerful use case is what we call lean back. Think about that block committee meeting in the video, or that surgical volume example, or the staffing example. Imagine those analytics being run in the background and being sent to the right people even before they asked a question. Imagine my homework being done for me without me even asking for my homework to be done for me. That's really powerful. Imagine a third use case that we call in-the-moment problem solving. I'm in the ICU, or I'm by a patient bedside, and I'm triaging them, and I need some help. And imagine asking a tool like IQ Autopilot, here are the patient's symptoms, what should I do? And getting a series of recommendations based on a qualified corpus of data that the model has been trained on. Some of these are more futuristic than others, but all of these are likely use cases that are going to happen in the next 24 months. Certainly many of the lean forward use cases and many of the lean back use cases. Now, obviously, there are dilemmas. We need to make sure these models work, can be trusted. And so most of what's going to be done first are probably the less what I'll call dangerous use cases, where getting it slightly wrong doesn't hurt us too much or our patients at all. But the power of being able to simplify, to be able to take the burden of the onerous and the burdensome and the repetitive is massive. So if you think about what the true promise of these generative AI tools are, it's really to help all of us function at the top of license. What does that mean? A lot of the repeated questions, the mundane tasks that we perform, much like in that airport example of checking people in or checking their bags in, should be done through generative AI. The right answer should be given to me when or before I even ask for it. That should help with a lot of burnout. If you think about the amount of time we spend at a shift change when nurses have to describe a patient situation to the next shift. Imagine all of those summaries being done through tools like this and automatically being generated. Imagine those nursing roster examples I gave you being automatically generated for us to be able to focus the limited amount of staff time we have on the more strategic items that we need to address. And this also helps us leverage our staff, give them more interesting jobs, and be able to do more with less. Not have to fill the staffing challenge or the staffing gap we have to the extent that we have it. So the real question is, are you ready? If you are, I would love to have you participate in this journey with us. Over the next few weeks and months, you will hear many announcements from LeanTAS, including the formation of a generative AI collaborative, where we already have 5 committed health systems that we're working with to create high ROI use cases that are low-hanging fruit. If you'd like to participate in any way, shape, or form, contribute ideas, be a petri dish for us to experiment together, use the output of some of these use cases that we're going to develop, just call us. You know where we live.